now we come to Dr. Shubhangi.
Yeah.
So supraoblique palsies, please.
Yeah, thanks a lot, sir, and I thank AIOS for asking me to be part of this IC. The superior oblique palsy is the most common cyclovertical muscle palsy which is encountered by an ophthalmologist. It could be congenital or acquired. Congenital are usually unilateral. One has to watch for contralateral hypoplasia. There's either defect in the nucleus or motor portion of the fourth nerve. And acquired is generally bilateral. It could be due to closed head trauma or the ischemic problems. There is an entity called as masked bilateral superior oblique palsy, where the palsy is more manifest in one eye and the other eye remains latent, and we have to identify it by the presence of V phenomena or head tilts. Otherwise, when we operate one eye, the other eye palsy will become manifest. So the diagnosis is done by measurement of ocular deviations in all the 9, basically a clinical diagnosis. All 9 diagnostic positions, right and left head tilt is important for diagnosing and planning treatment. Versions should be examined. Antagonists like infraoblique, infrarectus, superrectus in the involved eye should be examined. Park's 3-step test is important, though in about 50 to 70% of cases only it is applicable, or the sensitivity is 50 to 70%. Hess and diplopia charting and fundus evaluation for torsion are the things we look for. So, in cases of congenital palsy, it is more commonly a floppy tendon. So, primarily we shorten or tighten the superior oblique tendon, whereas in acquired superior oblique, the most common procedure is recessing the opposing muscle, that is the inferior oblique recession. If the vertical deviation is more than 15 prism diopters, we consider the recession of contralateral inferior rectus. If long-standing and the eye has poor depression, superior rectus is likely to be contracted and might require a recession. If X-cyclotorsion is significant, then Harada-Ito's procedure. So this is the video of exaggerated force junction test. We need to dip the eyeball into the orbit and then move the eyeball in the direction of supraoblique, so that we know whether there is a laxity of the tendon or tightness of the tendon, and many of our management strategies are based on how lax the tendon is. Now, coming to this case of congenital fourth nerve palsy, you can see a significant facial asymmetry. The patient had an R by L which was more in left gaze and right head tilt. There was about 25 prism diopters of R by L with 30 prism diopters of, he had an esotropia also in the primary position, and the R by L increased to 30 in the left gaze. There was a V-ESO and there was evidence of torsion in both the eyes. Now this is how the R by L readings in the 9 gazes, which was more in the levo version gazes, suggesting that right SO was more palsied. And this is the post-op picture after doing R&R in the right eye, right infraoblique recession with right supraoblique tuck, and the left inferior oblique recession. The V was reduced and the horizontal deviation was corrected. Now, superior oblique tuck is done in cases of superior oblique palsy, and I do it at the medial border of superior rectus muscle. We can do up to 22 millimeters of tuck. Non-absorbable sutures are used to suture the tuck, and I generally leave the apex unsutured. And at the end of the surgery, one should do an FDT to see that the eyeball is going beneath the midline, so as we're not creating a acquired browns. So this is how the surgery goes. Then the surgical techniques, the other surgical techniques which we do are the infraoblique recession, which is the most common, Harada-Ito, contralateral IR recession and SR recession. There's a NAPS classification which tells us which muscle to be done when the deviation is more on which side. So I'm not going in the details. I think this is infraoblique recession video. This we can skip. And this is another patient who had a small acquired superior oblique palsy. He had a small L by R in the primary position, which increased to the maximum in dextrodepression. He had maximum L by R in dextrodepression, and so we just did his right inferior rectus recession, which corrected his head posture and diplopia. And this was the HES chart, the pre-op HES chart, which is again showing maximum deviation in dextrodepression, which was corrected after doing the, yes. Now this was a case of traumatic right superior oblique palsy. She had an exodeviation with hypertropia, R by L, and she had about 10 degree of excyclotorsion. So these are the post-op images after doing the recession of lateral rectus, inferior oblique recession with Harada-Ito to right superior oblique. Now these are the pre-op HES chart, which is showing the excyclotorsion under action of right superior oblique and other changes, which is corrected post-operatively after the surgery. She was diplopia free after the surgery. This is the Harada-Ito. We know that the anterior 1/3 of the superior oblique muscle is responsible for intorsion, and the posterior 2/3 are responsible for depression. Here the anterior 1/3 fibers are separated, and they are then sutured to about 8 millimeters above the superior border of lateral rectus. METS has even proposed an adjustable type of Harada-Ito, which I have not done. And thanks for a patient listening.
Thank you, Shubhangi, for keeping it very, very